Before we dive in, please subscribe to the channel, like this episode, and drop your next requested topic in the comments. Those 3 clicks help us keep making exam-ready content for you. Welcome to episode 4 of Case-Based Scenarios on Nutritional Rehabilitation, Severe and Moderate Acute Malnutrition. Today, we will read anthropometry like a pro, choose the right site of care, and write crisp, high-yield answers. Dr. Joshi, thank you for joining us.
Happy to be here. Quick frame for exams. We use the World Health Organization Child Growth Standards with India's facility-based guidance at Nutrition Rehabilitation Centers, spelled NRCs, and community follow-up through Saksham Anganwadi and Poshan 2.0. Criteria you must quote are severe acute malnutrition, or SAM or SAM, is any of the following in a 6 to 59-month child. MUAC less than 11.5 centimeters, weight for height or weight for length Z-score less than -3, or bilateral pitting edema. Moderate acute malnutrition, or MAM or MAM, is MUAC 11.5 to less than 12.5 centimeters, or weight for height or length Z-score between -3 and -2.
Scenario 1. An 18-month-old weighs 7.5 kilograms, MUAC is 9.3 centimeters. How do we label this child and what is the protocol?
MUAC 9.3 centimeters is below 11.5, so classify as SAM by MUAC criterion, independent of the weight value. First, screen for medical complications in appetite. Red flags include hypoglycemia, hypothermia, severe dehydration, persistent vomiting, lethargy, lower respiratory infection, anemia with danger, or failed appetite test. If any are present, this is SAM with complications. Admit to an NRC for facility-based management. If none and the child passes the supervised feeding test, this is SAM without complications, eligible for outpatient care with frequent follow-up and energy-dense feeds per local program. India's current standard is robust facility-based care. Several states run community-based models in addition, but NRC protocols remain the national anchor. Protocol: facility-based for SAM with complications. Follow the classic 10 steps in 2 phases: stabilization and rehabilitation. Treat and prevent hypoglycemia and hypothermia, manage dehydration cautiously, correct electrolytes, give broad-spectrum antibiotics empirically, provide micronutrients, withhold iron until appetite and weight gain pick up, begin cautious feeding with starter diet F75, then transition to catch-up feeds F100 or energy-dense feeds. Stimulate, play, and prepare for discharge with counseling and follow-up. Outpatient SAM without complications. Frequent reviews, supervised feeding where available, deworming as per age, vitamin and mineral supplementation, immunization catch-up, and strong caregiver counseling on energy-dense local diets. Some states use community-based management of acute malnutrition packages with ready-to-use or locally prepared therapeutic foods under Poshan 2.0 convergence. Write that phrasing to show policy awareness. Pause and recall. What is single MUAC number defines SAM? Answer: less than 11.5 centimeters.
Scenario 2. Another 18-month-old weighs 8.5 kilograms, MUAC is 9.8 centimeters. Interpret status and differentiate management of SAM with versus without complications.
MUAC 9.8 centimeters remains below 11.5, that is again SAM by MUAC criterion. The weight being a little higher does not rescue the classification because MUAC and odema are decisive in the field. Management differences you must list are: SAM with complications, any danger sign or failed appetite test, admit to an NRC. Follow World Health Organization 10-step protocol, stabilize with F75, antibiotics, cautious fluids, transition to catch-up feeds, F100 or appropriate energy-dense feeds, begin sensory stimulation, plan discharge when clinical criteria and weight gainer achieved. Schedule follow-up. SAM without complications, manage as outpatient, frequent visits, supervised feeding, energy-dense home foods or locally produced therapeutic foods per state protocol, deworming, micronutrients, immunization and growth monitoring, ensure Anganwadi linkage under Saksham Anganwadi and Poshan 2.0 for supplementary nutrition and Poshan tracker enabled follow-up. Refer promptly if any complication develops. Exam tip: explicitly write NRC for SAM with complications, community or outpatient care with close follow-up for SAM without complications.
Scenario 3. A 3-year-old looks wasted. The growth chart shows a flattening curve over 6 months. Explain the growth chart, what a flattening curve means, and what is the next step.
The Mother and Child Protection MCP card carries weight for age and weight for length or height charts based on WHO standards. We plot serial anthropometry at each contact. The pattern over time is more informative than a single point. A flattening or plateau of the weight curve indicates growth faltering, an early warning of undernutrition or underlying illness before frank wasting or underweight becomes extreme. Next step, do a focused assessment, dietary intake, feeding practices, infections, deworming status, psychosocial factors, and measure length or height and mu-AC to classify SAM or MAM. If SAM by criteria, triage for complications, appetite test, danger signs, and refer to the appropriate site. NRC if complicated, outpatient if not. If MAM, enroll the child for supplementary nutrition through the Anganwadi Center, provide counseling on energy-dense home foods, schedule close growth monitoring, and address infections and deworming. State that this is under Saksham Anganwadi and Poshan 2.0, which integrates Anganwadi services, Poshan Abhiyan, and related schemes. Poshan Tracker supports monitoring. Pause and reflect, which is more important on the growth chart, one weight or the trend? Answer, the trend over time.
Scenario 4. A community survey finds several children with pot bellies, thinning hair and edema, differentiate kwashiorkor and marasmus, and outline dietary management principles in the community.
Definitions you can reproduce. Marasmus is severe wasting due to overall energy deficiency, marked loss of subcutaneous fat and muscle, skin and bones appearance, typically no edema. Classifies as SAM when WHZ less than -3 or mu-AC less than 11.5 centimeters. Kwashiorkor is oedematous malnutrition associated with protein deficiency and infections, bilateral pitting edema beginning in feet or legs, dermatosis or flecky paint skin, hair changes, sparse, easily pluckable, hypopigmented, enlarged fatty liver. Weight for height may appear deceptively normal because edema masks wasting. Any bilateral pitting edema equals SAM by definition, requires facility-based protocols. Community dietary management principles for MAM and for SAM after stabilization or discharge. Energy density. Enrich customary foods, add oil or ghee to cereal pulse mixes, use mashed banana, potato and rice with pulses, target 3 to 4 meals plus 2 energy-dense snacks daily. Protein quality. Combine cereals with pulses, add egg, milk, curd, groundnut, fish or meat as locally acceptable. Micronutrients. Ensure vitamin A, iron, folate as indicated, deworm per schedule. Safe water, hygiene and infection control. Treat intercurrent illness quickly. Caregiver counseling and play. Stimulate and interact daily to support catch-up growth and development. Link families to Anganwadi supplementary nutrition and HBYC home visits for sustained follow-up.
Could you summarize a clean exam template, classify, decide place of care, and write follow-up?
Use this 3-step spine. Classify with objective criteria. Check for bilateral pitting edema, measure mu-AC, if possible get the weight for height or length Z score from WHO charts. SAM equals mu-AC less than 11.5 or WXZ less than -3 or edema. MAM equals mu-AC 11.5 to less than 12.5 or WXZ -3 to -2. Decide the site of care. Do an appetite test and look for complications. SAM with complications or any edema, admit to NRC for facility-based 10-step protocol, F75 then F100 or appropriate catch-up feeds, cautious fluids, antibiotics, electrolytes and micronutrients, play therapy, and discharge planning. SAM without complications, outpatient care with frequent review and energy-dense feeds per state model, MAM Anganwadi-based supplementary nutrition and tight follow-up. Follow-up and systems. Schedule weekly to fortnightly checks until recovery. Ensure immunization, deworming and infection control. Use the MCP card growth chart to document trend and converge with Saksham Anganwadi and Poshan 2.0 services. Poshan Tracker supports monitoring.
Quick case drill before we close.
mu-AC 9.3 centimeters, irritable but alert. Then SAM. Screen for complications, likely NRC if any are present, else outpatient care with close follow-up. mu-AC 9.8 centimeters passes appetite test and no danger signs. Then SAM without complications, outpatient management with frequent reviews, energy-dense feeds, deworming, micronutrients, and Anganwadi linkage. 3-year-old with the plateauing weight curve for 6 months, then growth faltering. Full assessment, classify by mu-AC or WHZ, manage MAM via Anganwadi supplementation or refer SAM appropriately. Pause and evaluate. If you could write only one sentence on policy, what would it be? India anchors SAM care on NRC-based facility protocols with community follow-up and Anganwadi convergence under Saksham Anganwadi and Poshan 2.0.
That wraps our episode on nutritional rehabilitation, SAM and MAM, from crisp anthropometry to practical protocols and policy linkages. Dr. Joshi, thank you for the clear, exam-ready walkthrough.
My pleasure. Keep the cutoffs 11.5 and 12.5 centimeters and the NRC 10-step pathway on your fingertips for exam success.
If this helped, remember to subscribe, like, and tell us what topic you want next. See you in episode 5.